Hello, everyone. This is Lou Zacharilla, a founder of the Intelligent Community Forum, with another episode of our No Place But Home series. We're recording from New York today. It's April 29th, 2020. It's been 48 days since the World Health Organization declared this a global pandemic. There were 213,824 dead globally as of last evening, and 58,906 COVID deaths in the United States. That number will be over 59,000 by the time this airs. There were 27,359 deaths in Italy, which has the second greatest number. In New York State, it's been 60 days since the first case of COVID-19 is reported on February 29th. And in New York, the most current numbers are 330 people dead from the disease yesterday. And that is actually a decrease, and it continues to go down. There were fewer than 1,000 hospitalizations for the first time since the peak of the wave, again, here in New York State, where I live. The number of transit workers in New York City who have tested positive exceeds 2,500 workers, with 68 deaths from this disease. In Asia, Taiwan reported for the fourth day no new cases of coronavirus. On February 29th, in a New York Times editorial, Elizabeth Rosenthal of Kaiser Health News here in the United States noted that nearly 3 months after the late Dr. Li reported on the disease in Wuhan, at that time there were about 80,000 cases reported, that the world still did not have a clear picture of some of the outbreak's most basic information. And in many cases, that has remained a significant problem. Fortunately, our guest today has spent a career managing those types of problems and resolving them successfully. And he has spent a lot of time in the communication, collaboration, and the area of gathering information as it relates to medicine and technology. So we thought that we would have J. David Liss join us today if he can make the time. He's the president and CEO of J.D. Liss Associates, which is a firm that specializes in advocacy and communications in the fields of healthcare and technology. He has more than 30 years of experience in government relations in tech-focused settings. As the vice president for external relations at BioReference Laboratories, for those of you outside the country, that's one of America's largest testing labs. He was responsible for managing the company's interaction with stakeholders, including government. I met David when he served as vice president for government relations and strategic initiatives at my hospital, NewYork-Presbyterian, where he developed strategic resources to support the mission of what we believe is the preeminent provider of healthcare on earth. Mr. Liss holds a position with the Department of Biomedical Informatics at Columbia University, where he was previously responsible for technology transfers from Columbia's Departments of Medical Informatics and Computer Science. As you would expect with those credentials, he is at the center of the COVID-19 testing and knowledge sharing, and we couldn't think of a more eminent person to talk about where we are right now. So David Liss, welcome to No Place But Home.
Thank you, Lou. Thank you for that very generous introduction.
Well, it's of course all true. David, where are you physically located today, and what's the situation where you are?
Well, I'm in New Jersey. I'm working out of home in New Jersey. New Jersey is a state where self-distancing, where is required, is really required by the governor, and I think that's been very helpful for us. New Jersey, after New York, is the state most affected in the United States by the pandemic. I'll pick up where you left off, Lou. You were giving some numbers internationally and nationally. Here in New Jersey, we have 100, as of 10 p.m. last night, we have 113,856 confirmed COVID cases. Of those, we have 6,442 deaths, unfortunately, confirmed COVID deaths. And these numbers will probably increase by the time this is aired. Our hospitals, we have 71 hospitals in the state of New Jersey, and there are 6,478 cases currently in hospital in the state. And that's actually a reduction from the number in hospital over the past few weeks. So that's a good thing. Of the 210,000 people who have been tested for the disease here in New Jersey, almost 90,000 have tested positive. So we have a positive rate of about 43% here in the state. So it's had an enormous effect on where we are.
And that's extraordinary. And of course, again, for those of you outside the area, New Jersey is part of the tri-state region, along with Connecticut. And so, David, I would guess that those cases are, again, the result of the density within this massive metropolitan area. You know, I referred to that Kaiser News article as sort of an example of how difficult it is, despite the celebrations that we make about big data and managing data and being data driven, the challenges that we still seem to have with regard to gathering data, coordinating inventory information, performing research on a collaborative basis. And I'm guessing that one of the outcomes from this epidemic will be perhaps a better format for collaborating to address, you know, these things as they break out. But having said that, you are involved with the New York eHealth Collaborative, which is a type of response community. And you've been doing some really significant work that's been applied here in New York. Tell us a little bit about that New York eHealth initiative and the kinds of things that you guys are doing to sort of get a jump on what I've identified as a problem.
I should probably give just a little bit of background on what the New York eHealth Collaborative does. We are a public-private partnership under the rubric of the New York State Department of Health that oversees health information exchange and health information technology for the state of New York. This is a project, again, more than 10 years ago. And it sounds an awful lot like a technology project. Do we have the backbone? Do we have the internet? Do we have the servers? This was really a policy project, and it was really a collaborative project. So where we started was with general agreement among the healthcare providers, the patients, the patient advocates in the state that there is value to sharing healthcare information. That it's absolutely necessary if the state will meet its population health goals, where there was agreement as to what needed to be done and who should do it and how we participate. We started building. And New York State has now, in the last 10 years, put more than $1 billion into the ground in terms of infrastructure and how we run these things and how we pay for these things. So the New York eHealth Collaborative is responsible for the State Health Information Network of New York. That is the backbone that unites the state of New York. And we create the rules, we create the policies, and it turned out to be a significant asset, Lou, in responding to this. It could be an asset anyway, but what it's allowed us to do, and I'll tell you just 3 things right off the cuff that we've been able to do with this technology infrastructure. First of all, we're sharing lab results across the state. So if somebody, we're doing a lot of testing, if somebody tests positive, somebody tests negative, we can report that. That information becomes available to the Department of Health for public health purposes, for disease tracking, for understanding the hotspots for the state to understand where resources have to be deployed. Another thing that we're doing is we report episodes of care. So if a patient presents in an emergency department, that information is now available to his or her physician. It's available in other hospitals if the patient presents in other hospitals. So being able to track a patient across episodes of care has turned out to be incredibly helpful for this. And then, you know, on the more dramatic side, in New York, we found ourselves so overwhelmed. We found every hospital was overwhelmed with COVID patients. And we found that we were not able to care for non-COVID patients since the entire hospital is being turned into an ICU. Working with the federal government sent resources, and we turned the largest convention center in New York City, the Javits Center, into a 2,500 bed hospital. Well, now we could offload, the hospitals could offload non-COVID patients, trauma, cancer, necessary surgeries. We could unload those patients to the pop-up hospital in the Javits Center, but those patients were presenting with no records, no data. Every encounter was starting from scratch. What we were able to do, because we had the State Health Information Network of New York, is set up workstations there and take the entire patient record and make it available as needed.
David, that's remarkable with regard to what you guys were accomplishing at the Javits, because that got put together very, very quickly. We were all worried that we were going to get totally overwhelmed. And I wasn't aware that the eHealth initiative was even involved. Was that getting set up in real time? And the information was coming in real time as well?
Yes, actually the way the network operates is that a query is sent to the network in real time, and edge servers put together the patient record on the fly. The patient record is available, is used, but it can't be stored. And so when the encounter is over, the patient record goes away.
Right. And again, fortunately, that was available. With regard to, the other question I had was, how quickly is the information shared with doctors, different providers in the system?
So a lot of that, the drivers behind that is the provider a participant, and does the patient have, has given consent, has the patient given consent? In New York State, where we have the network operating, 100% of hospitals are participating. 66% of clinics largely have QHCs, that would be federally qualified health centers. 57% of physician practices are participating. And that's the most difficult link of all, because these can be very small 1 and 2 physician offices. And then about 80% of the long-term care centers in the state are participating. So in terms of being able to reach the providers, for the information to reach them, we're in good shape. In terms of consent, slightly more than 60%, 60% of New Yorkers have given consent for their information to be shared on the network. And so you could get to the availability of information by looking at who's participating and the likelihood of the patient to have given consent.
That's extraordinary. I just want to continue on this theme of collaboration, let's say. I mean, that ICF, we're just obsessed with collaboration within cities, among cities. We think it is the secret sauce, really. We don't claim any, great magic, but if you collaborate, if you share your data properly, as you've just described, you can have good outcomes. I was struck that hospitals in the state, by and large, did not share inventory, that there was no real mechanism among the private and public hospitals that I could tell that really could mobilize, but the governor seemed to pull it together very quickly. And so there must have been some sort of backbone behind that, in addition to his, and I also noticed the same thing with regard to research data. The journal Nature, the publication Nature, was begging researchers to release information more quickly, as opposed to sort of keeping it until it was pristine. And the idea there was that you don't hold data in a crisis like this, even though it's gold for your career, because there's a public good at stake. Is there a balance going forward that you would advise cities and states and regions to put into place to make sure this information gets shared more rapidly for the next crisis?
It's really hard to beat culture. Culture is the great barrier. Just like sometimes it's the great facilitator, it can be the great barrier. And the culture of academia is very much to treat your data as if it was your child and hold on tight. Having said that, first of all, I think the culture is changing. And I think that in a universe that has crowdsourcing, in a universe that has social networking, there's, among young researchers, a greater willingness to share. I'm thinking about one project that I've worked with called Odyssey, OHDSI, and it stands for Observational Health Data Science Initiative. Odyssey is international in scope. It's on every continent. It's in almost every European country. It certainly includes every academic medical center in the United States. And it's a project that is sharing observational data out of the patient record for the purposes of research. It reminds me so much of actually the work you do, of the Intelligent Cities Forum, because what this group has done is say the greater the body of data we have, the more rapidly and the more effectively we can do observational research. They have 600 million patient records that they have access to, because every country, every city, and every institution that chooses to participate provides its patient record data, and then in return receives the massive body of data available. What they spent 6 or 7 years doing was developing a methodology that allowed for the sharing of unlike information. That's where the work was. But having done that work, they were now able to approach institutions and nations and cities and say, here's what you get if you join. So I think that culture is changing, and Odyssey is a very, very notable example of how that is changing. So part of the answer to that, I think, is not to make the effort, Lou, to change the culture and say, no, we've got to do this because it's in the interest, the greater good. I think one way of approaching that problem is to say, how do I benefit my institution, my city, my nation? What can I participate in, and what's the cost of doing that? There are options. That creates channels, and it would be worthwhile for cities to look at that now to try and answer that question.
Well, I was just thinking that, David, and that's fascinating. Do cities have access to this through their healthcare networks, or is it can a municipality participate in this, or is there?
Well, there'd be two pathways, I think, for a municipality to participate. One would be through its Department of Health. Departments of health have an enormous amount of data that has great value. Public health data that's worth its weight in gold right now. And so through their departments of health, they could participate, but also to the extent that there are relationships between the municipality and its providers, and particularly hospitals, that would be another pathway.
Okay. I want to switch to communications because, of course, J.D. Liss is noted again for having expertise in communications, and especially in a time like this, it would be invaluable. Is there something that those, again, listening to this who are soon going to experience their outbreak should take away with regard to communicating effectively at the outset of this outbreak? Are there steps that you would have advised them to take?
Well, step number one, I hate to offer a retrospective step, but start now, and start now, even if it's not necessarily going to be immediately useful for this pandemic, but because you need to build the foundation. So find things to talk about. If my history goes back, I mean, I worked for New York City government decades ago. In fact, I worked in the Koch administration. And
I didn't realize that, yeah.
I was a speechwriter. And many stories come from that. But one of the hallmarks of city government had been, and certainly at least this was true in New York, was the belief that we could do it all, that we had it all, and that we didn't need to talk to others other than to have one-way communication from us to them.
Right.
And over the years, seeing city administrations come and start to expand that communication and make it two-way was really important. So my advice to cities is, for the pandemic, specifically for the pandemic, define a set of very achievable communication goals. We need to share this information this frequently, and I'm sure they're doing that. the people who run the cities that are members of the Intelligent City Forum are very good at this kind of thing. They should probably continue to do what they're almost certainly doing, which is defining the information sets that need to be shared. They should make a point of being able to define what is important to the people they're communicating with. So just as hospitals need to report to the city positive and negative cases, cities should be taking that data, crunching it, creating demographic heat maps. That information should be returned to the hospitals so that they could do resource allocation.
Do you see a lot of that? Is there enough of that going back and forth? Because that seems to me both obvious but brilliant if you've never heard it before.
Unfortunately, there's not a ton of that going on, but more than there ever was before. When I worked in government, there was zero. And now more and more, in New York in particular, New York City has found ways of structuring that. So there are trusted entities in New York. They include the Greater New York Hospital Association, the United Hospital Fund, and these trusted entities become coordinating centers for the sharing of information. The New York eHealth Collaborative has become a trusted entity for describing information needs. So your members may start thinking about how do we either identify or construct trusted entities for this communication to happen.
Yeah, and as you say, a lot of them have already gone down that path, and the trend line that we're picking up is that what they set out to do, as you described at the outset, was to make themselves, the city, as the source of reliable information so that they would be trusted as things started to heat up and as it got worse. So
you can imagine in New York, and you're very familiar with New York, and New York has a number of academic medical centers, and they're very competitive with each other. Getting them to work together has always been a challenge. The city can serve as a trusted broker. Government can serve as a trusted broker.
Absolutely. Yeah. And then when we talk about our collaboration, again, that's just another example. Well, speaking of trust and things that are very, very critical right now, you have a second role which you play, which is vitally important with BioReference Labs, which is, I believe, the third largest commercial lab in the United States, and of course the largest provider of COVID-19 testing. Tell us about the work taking place now and some of the outcomes that you're expecting with the work that you're doing for New York City's Health and Hospitals Corp. And other cities.
You're correct. We are BioReference, which the company I represent, is the third largest commercial lab in the country. We're about $1 billion in revenue, and we historically have been strongest in complex specialty testing, things like genetic testing, cancer testing. Obviously, we do infectious disease testing. When the pandemic was on the horizon, we took a look at that. Pathologists took a look at that. We kind of had a sense that it was a tsunami. And so we prepared. And we prepared by buying multiple platforms to do testing. Commercial laboratories like ours, we're very good at doing massive amounts of testing. We're very good at the logistics behind amassing the test and processing them, getting the patients in, getting them out, getting the data to where it needs to be. I mean, it's what we do for a living. In the case of COVID, because there were so many question marks, what we invested in were not a single platform to do testing, a Roche or an Abbott. There are multiple companies that produce these platforms.
Right.
We actually invested in 5 separate platforms. Our expectation was that there would be an overwhelming number of patients, that our equipment would fail at some point, that it would have to be repaired at some point, and that we would need to keep testing. So we invested in 5 different platforms, and that was a very effective strategy. And why today we're doing 20% of all COVID testing in the United States. The client is government. The client is city government, county governments, state governments. Those are our clients. And what we've done is provide the infrastructure to allow city and state and county departments of health to set up testing and get rapid results back. When I say rapid, I mean 24 to 48 hours. Currently in New York State, we are doing 35,000 tests per day. And nationally, roughly 100,000 tests per day in different markets. And now we've started doing, starting in New York, we've started doing testing for antibodies. So there are really two types of tests that need to be done. One is to detect the diagnostic, to detect the disease. And the second is serology, or testing for antibodies that demonstrate that somebody has had the disease and most likely has a certain level of resistance. Now, if you can imagine restarting an economy, getting people back to work, you'd want to know who has the antibodies and who is likely to be resistant to the disease. And so we've started antibody testing in New York, and we're up to 10,000 a day. We're going to grow that to 100,000 a day.
Very good. And of course, everybody's waiting anxiously, for that, because we do want to reopen our doors. David, I mean, testing is a big issue now. I think the White House said on Monday that we're lapping the world with regard to tests, but the media is saying, well, no, you haven't performed on the numbers, et cetera, et cetera. And it goes back and forth. But in New York State, where the governor, has clearly articulated what the staging needs to be, I think everybody understands where we need to go. What is the major challenge with scaling a testing regimen, say in a state like New York, which is the epicenter of COVID right now in the United States?
You've heard probably some of this in the media, needing access to supplies, so reagents and swabs and transport tubes. So one issue is access to supplies. An issue that BioReference solved very rapidly, but others have had more difficulty solving, and particularly at I would say for your membership in particular, where state departments of health and county and municipal departments of health have had a great deal of trouble scaling, is being able to run multiple platforms for multiple tests.
Right.
Service. Departments of health tend to focus on, because the procurement processes are so complex and difficult, they tend to have a single platform that they work with. Something goes wrong, it creates a real bottleneck. So being able to be very flexible on procurement, being able to stand up more than one platform at a time, and maintaining access to supplies are three really critical barriers.
Right. And again, just very quickly, in the area of preparation, should a community or should a group of communities be prepared to have multiple platforms, years in advance of something like this happening? Or is it just too expensive, too cumbersome? And I wouldn't advise it because I know too much about technology. The platforms will be outdated.
Well, I think you've hit the nail on the head, Lou, but what I have to remember is I'm speaking now to the Intelligent Cities, Intelligent Communities Forum. And so your membership has an opportunity that I think other communities may not have. My laboratory had to have multiple platforms. We had to make a very rapid investment. We're a private company, so we have access to capital, and our decision-making process is very flat. Your members probably don't have that, but what they do have is the ability to share information because of the infrastructures they're working on, so that if a Department of Health can survey its hospital labs and its commercial labs, find out what platforms they're operating, and then do traffic management between them, it's going to be a very, very effective way of managing something of this scale.
And I do believe that. Last question, David. When I told some of our cities I was going to speak with you, they got very excited about that. What we're going to accomplish, we've already had some conversations in Taiwan, when this is over, is to bring together our about 200 cities to talk about ways that we can prepare city to city to city for future events like this. Knowing what you know about the ICF, of course, you've spoken for us and before. Is there anything that you would advise as sort of a next step to put together a collaborative like that?
Yeah, I mean, what an opportunity. I think the most important first step would be for your membership, to what extent do you have members that are in the same national borders?
We have an ICF Canada and an ICF Taiwan organization, which represents clusters of cities in those particular nations. We'll probably have one in Australia before too long, but otherwise they're pretty spread out.
One thing to do is for your membership to determine which cities have traffic between them, because it's really crucial. And where people are dropping the ball, cities can be very effective at monitoring their borders. They tend to do that well. What they tend to do poorly is monitor traffic that leaves the border, that comes across the border. So I had a conversation, for example, with somebody in county government in Texas who was expressing some concern about their ability to do testing and some concern about the state governments putting resources behind it. Now, this was a county in Texas that was very close to the border of Louisiana. And it was pointed out to me that they understood Louisiana was the fastest growing coronavirus population in the country. New York is the largest, New Jersey is second largest, Navajo Nation is the third largest, Louisiana is the fastest growing. What the state did was bring the state troopers to the airports to interview people who were coming from Louisiana to say, if you're coming in, we need to know where you're going to quarantine for 14 days. What wasn't being monitored was where 90% of the traffic came. It's over the border from driving. People would drive from Louisiana to Texas. And so 90% of that movement was lost. So a very good thing for the ICF cities to do is to, first of all, look at movement between them and determine how they're going to gauge that. Because that creates the opportunity to share information. Another very important thing for the ICF cities to do is to standardize how they report data. That is one of the great barriers that we're facing here in the United States, is that we are able to collect the data, but sharing it becomes difficult. And for those of your members who don't do technology, don't spend a lot of time with technology, computers are really dumb. They know what you tell them. And when I look at healthcare terminologies, and I think about some of the issues we've had early on, and I've been doing this for many years, early on, one of the problems we faced was if we want to take patient information from one hospital and give it to another hospital, one of the most important things you could identify is gender. Except that hospital A reported gender as male and female. Hospital B reported it as 1 and 2. Hospital 3 as M and F. And trying to share that information became impossible because one system couldn't recognize the data from the other. So the ICF cities are in a great position to work with each other to standardize data reporting. And frankly, if they did that for each other with 200 cities, if they could create a standard reporting format for infectious disease, there are existing vocabularies, there are existing syntaxes that they could use, but if they could standardize amongst themselves, they'd be doing the whole world a favor. If they could create a standard reporting format for infectious disease and just publish it, they'd be doing the world a favor.
Well, and that's exactly what they want to do, and I think that's terrific advice. It's always been our mission to do that, to collaborate in that way and to put out best practices. And I think this is what you've just described is a great way to do it. David, thank you. We could go on talking for hours, of course, but I have to let you go. I want to thank you, though, for making the time to be with us today, because I know, obviously you've got a lot going on right now.
My pleasure, Lou. Thank you for the opportunity.
And we'll talk to you again. For more information on David and his firm, you can visit jdlissassociates.com. The No Place But Home series is produced by ICF as a service to its network of intelligent communities and our followers around the world. A shout out to our producer, Matt Owen. Join us next week for another conversation. And if you want to view prior conversations or just watch the conversation with David and I again, go to intelligentcommunity.org/COVID-19. And you can follow us on Twitter at New Communities and Lou ICF. I am Lou Zacharilla, reminding you that there really is no place like home. Take care.